Thank you, Kelsey. All right, it's time for our Q&A session, so I would love to invite Jane Mcdonald, who's our Executive Director of the Foundation. Jane is going to moderate and curate the questions, and if we could have our guest speakers on the stage, feel free to take a seat. Maybe we'll pull them forward a little bit, so you'll be more comfy.
Perfect. Hi, everyone, and thank you so much for being here today, and our panel is now nicely mic'd. Thank you so much, speakers, for all of the information you've shared with us. And we have several questions, so we won't get through all of them, but we'll try and address most of them. And then as well, encourage everyone, please, 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 while we're doing this Q&A, fill out your surveys so that we can include you in our draw at the end. So it is now 3:42. I promised Steve Sleep that we are timely here at MedTalks, so let's let it go. Okay, so number one, okay, this is going to be a technical one for you, Dr. Mills. Do you start moisturizing your vagina before it starts to dry out, or wait until you are dry?
We knew this was going to be fun, right?
That's the first question.
I think that's a great question, and I think that women want to try to approach their health preventatively. I would say that if you aren't suffering from any symptoms, then you don't need to pursue any treatment. But, you know, the symptoms sort of creep up insidiously. So maybe just having an awareness once you're in menopause to sort of check in with yourself about what your symptoms are. And then, yes, using a vaginal moisturizer for day-to-day and then lubricant for penetrative intercourse is extremely helpful.
Excellent. Okay, one for Dr. Gordon. If you already know you have dense breasts, how often do you need to have a breast exam? And are urethral Karnicles common in menopause? What are the long-term effects of estrogen cream insertion? So let's start with Dr. Gordon, then go Dr. Mills.
So if you already know you have dense breasts, first of all, I would recommend you do breast self-examination for sure, even if you don't, but especially if you do. And I think the screening program now allows women to book, if you don't have a mother, sister, or first-degree relative with breast cancer, you're only supposed to go every 2 years, but they'll let you phone at 22 months and book. So don't let it go beyond the 2 years. If they're going to start sending out reminder letters after 2 years, but you know what happens, you get the letter in the mail and you say, yeah, I'll get around to this, and 3 more months goes by. And since we already know that 2 years is too long, it would be better if you went at 1 year. Try to put it in your calendar on the day you have your mammogram. Okay, 22 months from now, I'm going to call and make my next appointment. And hopefully, before long, we'll have managed to persuade the screening program to offer screening annually again. But that's self-exam. Make sure you have your mammogram as often as you can. And I realize that your hospital is not in a position at this point to offer screening breast ultrasound. And it's very hard to get anywhere in the province just because of the shortage of techs.
And the second part of that?
Okay, so there was something about a urethral Karuncle, and then was the other one about safety of vaginal estrogen? Was that it?
Long-term effects.
Long-term effects. Okay, so a urethral Karuncle is when the urethra, which is where urine comes out, it sits at the top of the vulva, and in premenopausal women, we don't often see the urethra unless we're really inspecting. For postmenopausal women, it can be very prominent, and it can get quite beefy, red, irritated. So we treat that often with topical estrogens. You know, there are women in their 100s who have been on vaginal estrogen for 50 years. Vaginal estrogens have been around for decades and decades, and so the current thinking is we do not have any concerns with long-term vaginal estrogen use as long as people are using it as they were prescribed. I mean, if you're using it 3 times a day with big gobs, you can get yourself into trouble with the lining of your uterus like that, but if you're using a small amount as directed twice a week, then there's no concern with long-term use.
Right on. Okay, Kelsey Oxley, would traveling mammography units be an element to increasing compliance in getting mammograms? And back to Dr. Gordon, why is this task force still operating? So let's do the easy one first.
I mean, I think I answered that. We do have the Mammo West coming. We were only able to get it for 1 week, but it will be significant in helping with our wait list.
So the task force was disbanded in 2005 by the Liberal government, and in 2010 it was reinstituted by the Conservative government, and when they did so, they based it out of the University of Calgary, and I don't know if you remember, there was a science suppression scandal where the Conservatives told scientists, you're not allowed to speak to the media about your research without going through us. And this task force is funded by the Public Health Agency of Canada, from the Ministry of Health, and they're not accountable to anybody. There's no oversight. And I am working with colleagues across Canada to try to get them to disband it again. But it's really tough. And what would be great, so Dense Breast Canada, I mentioned, is that nonprofit advocacy group. They actually have an online petition. If you go to densebreastcanada.ca, there's a petition you can sign. There's over 85,000 signatures so far saying we got to get rid of this task force. But so far, that's not enough signatures. Anything you can do to bolster that would be great.
Okay, thank you. Question, and I'm going to leave this up to you to answer. How do we find out if we have the genetic mutation for increasing cancer risk? Who do we call? Where do we go?
You, first of all, it's extremely unlikely that anybody would have a mutation unless they have multiple relatives in multiple generations with usually breast or ovarian cancer. So if you do, then the family doctor should refer you to the hereditary cancer program at BC Cancer. There's a long wait list. It's about 18 months right now. And what happens is they then take your whole family history. It's called a pedigree, and a whole bunch of other information, and they will decide if you're a candidate for genetic testing. It's just a blood test, but they don't just say stick out your arm and we're going to test you now. First of all, they have to educate you as to all the implications of knowing whether you're positive or not. So for example, if you haven't got all the life insurance you ever want to buy, you may not want to have the test because it might make it impossible for you to get insurance. And there are women who say, I am not prepared to have preventative mastectomies like the Angelina Jolie effect. There are women who say, I'm not going to take the cancer prevention drugs that are on the market. I'm just going to have extra screening. Well, that's fine, but you might not want to do the test. One of the upsides of knowing whether you have a genetic mutation is that then you will be eligible for annual MRI through BC Cancer in addition to annual mammograms. But it's a very long process. Speak to your family doctor and don't even bother trying to get an appointment with BC Cancer Hereditary unless you have multiple relatives in multiple generations.
Thank you. Okay, we've got a sort of three-part question here. And Kelsey, Oxley, maybe you can help us with this. Where are we at with allowing mammograms without an MD or nurse practitioner referral? Why are women over 80 oftentimes told that it's not necessary to have a mammogram? And what can a woman do to address symptoms of having a diagnostic test when they don't have a clinical provider?
I honestly don't know where we're at with having people identify, that they don't have a family practitioner or a family doctor or nurse practitioner. I don't know the workaround. It's in progress.
I've been in touch with the head office multiple times, and apparently other provinces do let women self-refer without a family doctor or nurse practitioner. And what I'm told is, well, what are we going to do if they have an abnormal mammogram? How are we going to make sure they get followed up? I think there are other provinces that have programs for what we call orphaned patients, the patients that don't have a family doctor. And this is a growing problem. They need a little pressure to deal with it. So write a letter to our Minister of Health, Adrian Dix. And I have often said, medical systems don't listen to doctors, but politicians listen to voters. So write a letter, make an appointment with your MLA, and get them to advocate for you with the minister.
Maybe they'll give you their family doctor.
And, oh, sorry, the women over 80, that's an education gap for family doctors. Like I said, they're not up to date. If you don't have something else, your breast cancer risk keeps going up. And even if an older patient is frail, if she has screening and we find a small cancer, they can do a lumpectomy under local anesthetic. Better to get it out than let it fester, and when a cancer grows, it can penetrate through the skin and ulcerate, and then it becomes a smelly nursing nightmare. So better to find it, and even if she's not going to have full-blown cancer surgery, let's at least take it out.
Right on. Okay, Dr. Mills, I think I have a three-part for you. So, if you are over 65 diagnosed with osteoporosis, taking Prolia twice a year, how often should you have a bone density test and where can you get one? Should you start hormone therapy before menopause, that is before the anniversary of the 12th month of your last period or after? And then lastly, can you say a little bit more about the connection between anxiety and hormone changes in menopause? And what is the biological causation?
Those are three excellent questions, and I may need you to either look at them or have them repeated for me, Jane. So the first one was about bone density.
Yes.
Is that right?
Yes.
And the question was, if you've been diagnosed with osteoporosis and you're over the age of 65. Okay, so a lot of osteoporosis care either falls to bone specialists, which are endocrinologists, or family physicians, which also have a wealth of, or nurse practitioners who have a wealth of information about bone health. I mentioned in the talk that the current recommendation is for all the population to have a bone density, which is an X-ray test, done at age 65. It is not a painful test. There is no dye. There is no IV. You don't have to fast. I can't comment on the Sunshine Coast as to. Okay, so not available on the Sunshine Coast, so you would have to travel. Currently, there are very few situations in which we do bone densities more often than every 3 years because bone changes are slow. But whoever is prescribing your Prolia should be able to answer that question as well. Okay. And the other question was, should you start hormone therapy before your period has stopped?
Yes.
And I guess that depends on what symptoms you're trying to control with the hormone therapy. So we're not generally using HRT preventatively to reduce risk of heart attack or things like that. But there are some women who have severe hot flashes and night sweats, and they're still menstruating regularly. So yes, hormone therapy can be helpful for those people. And then the third one.
Connection between anxiety and
Right.
hormonal change
Yes.
in menopause. What's the biological causation?
Yeah, so that's a great one. So what a lot of people will describe as a source of anxiety is the sensation of the hot flash itself. So a lot of people will say they're sitting there, they feel totally fine, and then they start to feel this heart racing, palpitations, their throat is choking up, then they feel the progressive warmth spread up through their chest into their face. Then the body says, I'm really warm, what am I going to do to maintain homeostasis? And it vasodilates everything, so then women sweat, and then they chill and shake. And so a lot of people, there's a sense of anxiety associated with that event itself. It's physiologic. And a lot of people will wake up at night. They may say, I woke up at night feeling anxious, and then like a night sweat happened right after. So there's anxiety in that context. And then there are people for whom they may be more susceptible to hormone-mediated anxiety. So these are women, for example, who are at risk of postpartum anxiety. You're then at increased risk of menopausal-related anxiety. And there are some women who find that having hormone therapy can help mitigate that.
Awesome. Kelsey, Oxley, a question about obtaining the dates of all of our mammograms. Do you keep a record, or thanks to our new computer system, does every patient have a record of how many mammograms they've had or their dates?
Oh, absolutely.
Okay.
Yeah, it goes back, if you've not had any mammograms, they're not kept for a period beyond 10 years. the data is not as retrievable, but if you've been coming regularly, it's absolutely retrievable, and everything that you've had done across BC is easily retrieved in our systems. And then if it's, was in Toronto or Edmonton, we just request the information from the other offices, and we can compare as far back as you've had mammos, and we definitely do pull them for each and every visit for the screeners or like anyone reading your imaging to review.
Fantastic. I think I'm going to pause now, and there are a few extra specific questions for you, Dr. Mills, so I think we might just correspond with our audience privately on a few of these remainders.
That means vagina questions, I know.
No. Anyway, there was a mention of a purchase that's happened recently, and I asked Michelle Stanton to be here, who is our acute services manager for Sechelt Hospital. And thanks to the Sechelt Sunshine Coast Healthcare Auxiliary, there has been a recent purchase of a neoprobe. And could you tell us a little bit about that and how that impacts breast health and breast procedures, as that's definitely outside of my pay grade? Michelle?
I'm your bonus section. So Kelsey Oxley, when she gave her presentation, mentioned some increase in our surgical services here locally. I'm the manager that oversees our surgical department, including our operating room. And so I can let you know that recently, through the support of the Sunshine Coast Healthcare Auxiliary, we've been funded to purchase a neoprobe. And we also recently had a new surgeon join our team. So Dr. Coldebaran, I don't know if many of you may know him or may not know him. And part of his practice is breast surgery. So in recent years, we haven't been able to offer that service on the Sunshine Coast. Anyone needing any form of breast surgery has had to go to Vancouver. When we get our program up and running, which I'm hoping will be early fall, but we're just still waiting on some final pieces with that, Dr. Coldebaran will be able to take referrals from your family doctors, or if you've been referred to Vancouver, you can ask to be referred here if it's not going to delay your care. And we will be able to offer mastectomy, lumpectomies, biopsies, fine wire biopsies. And the neoprobe itself is a device that, in conjunction with a trip to Vancouver to Lionsgate Hospital to nuclear medicine, you will have injections done the day before, and then you come and through the nuclear medicine, it travels in, it highlights sentinel nodes. So the sentinel nodes are the nodes that if there is a transmission of cancer, and I'm gonna let the experts tell you more about that, will be the node, the lymph node, that will show up first. And with using this device, they are able to track that through the neoprobe device and the injection you had the day before, and biopsy or remove those nodes.
Thank you. Thank you. All right, I think we're going to wrap this up today and say thank you so much,
Jane,
everyone.
can I interrupt?
Yes, by all
I was
means.
asked to comment on this, and I didn't find a better time to interject.
Okay.
Apparently, some people are asking about thermography. And thermography is a test that measures temperature, and it's surface temperature. And it's being peddled as an alternative to mammograms for screening. And it is completely discredited. You can Google thermography FDA. It is, it can find great big cancers close to the skin that can measure the, change the temperature at the surface of the skin, but it has way more false alarms than any other test. Just about every single one comes back showing something that needs follow-up. Right. They're available privately in some places, and they can't find the small cancers that we aim to find with accepted screening modalities.
Thank you very much, and thank you for warning everyone of that. So thank you very much, presenters. I'm going to let you get off the stage, and I'm going to ask our ushers today to collect any of the survey questions you'd like to submit. We have 5 fabulous prizes, and thank you. You can take that as well. For all of your attendance, and we really appreciate everyone being here today. The exhibitors will continue on with the health fair in case you didn't get to see them before the MedTalks. So if you have any questions, please stop by our exhibitors. They'll be here for another half an hour. We are looking for some feedback on our next Med Talk as to the topic. We have a notional idea that we might be talking about cognitive decline supports and caregiver supports in community. But if there's something else you'd like to learn more about, we could probably do 5 more Med Talks on women's health alone. So we really appreciate your feedback, and I'm going to rely on my ushers to give me some baskets to draw for our winners today. So 1 second.